Good evening, my name's Peter Ashby. I'll be doing my obstetrics scenario with you tonight. So we've been called out to an imminent birth, probably, or an abdo pain. We're wearing PPE. We've done a 4 at the door. We're assessing for corona risk. Do a global overview of the patient, introduce ourselves. Hi, my name's Peter from the ambulance service. What have you called us for? I'm having my baby. Fabulous. What does it feel like? I'm having contractions. Okay, so I've touched her hand. A, B and C are done. I know her pulse is good. I'm not concerned about her circulatory system right now. I'll say, do you mind if my partner does your obs? I'll get a baseline of obs right there and then. Okay, no problem. While he's doing that, I'll just have a quick feel and do a PQRST. What's it feel like? Contractions, right. When did they start? Okay, how bad's the pain? Would you like some pain relief for that? I can give him methoxy if I'd like at that point anyway, but I'd probably withhold right until the end, or unless the pain was excruciating. I'm feeling her tummy. I'll do a proper quadrant check and probably feeling that whole area would contract along with contractions to say, yeah, she's got a baby in her tummy and there's contractions there. I do an ecology assessment, so asking the exact date of conception, knowing where we are with gestation here. If it's a viable baby, we'll ask about those contractions. How long have the contractions been going for? The length and the duration. When are they? The frequency. Sorry. How often are they coming? Between 2 and 5 minutes, and for frequency, and between 45 seconds of length. That's an imminent birth, and at that point I'll ask my partner, hoping that all the obs are within flags or within reason. We don't have to make any interventions, that he can go get extrication sorted and get us a crew ready. I'll ask Mum, are you expecting twins? So we'll know if we need 2 crews. Hopefully an IC crew will come to back us up. I'll get the PAL team on the phone. The PAL team's a MIDI crew that will talk to me and give me advice if this does go wrong and it's not a perfect scenario. After that point, I know we're having an imminent birth, so I'll also be timing it myself and confirming the length and frequency of these contractions. I'll ask her those other obstetrics questions, so her GMP. How many pregnancies have you had? How many viable babies have you given birth to? Whether she's had C-sections in the past or successful vaginal births, whether she's been getting prenatal care, and whether she's got her card ready to go with us. Whether she's had her fluids break and what colour were they, when did that happen, how much has she lost. Important questions for our handovers. Make sure those obs are within flags, and we've already intervened. I'd get my partner to intervene on those, so she needs cannula for hypovolemia, etc., or little oxygen to help support her. Ask her her gynecological history as well. Do you have cystic endometriosis or ovarian cysts in the past? That's good for our handover. I'll complete my sample questions too: allergies, medications, past medical history, so her risk factors as a patient. Does she use drugs, recreational drugs, anything that would suppress the baby's respiratory status when it does come out? Interesting stuff. Alright, so she's having contractions. I want to have a look. I get consent and make sure it's culturally appropriate. So we do need to have a look. With her contractions, I want to be looking if there's any pursed, her anus is pursing, or whether there's any head exposing or coming backwards and forwards. If it's turtling, I need to talk to the PAL team and we'll talk about shoulder dystocia, but it's not, and the baby's facing downwards towards her anus, so it's you can see some of the landmarks, so we're in a good position. So baby's head, as it births, should turn at the time she's birthing, and I'll ask her not to push too hard, to try to refrain from pushing too firmly, and I may even add a little back pressure to reduce the tearing on her vaginal passage. As it turns to the side, the shoulders should get stuck a little bit. I'll wait for the next contraction, adding downward pressure for the baby and getting that first shoulder out. Noting the time, of course, when the baby's head comes out, I'll be calling it baby's head is out. PAL team should record it, or my partner, with the next contraction, also doing a lifting motion. Then to get the second shoulder out, and after the second shoulder is out, there's nothing else to hold the baby in. Baby should come out pretty easily at that point. Avoiding grabbing the umbilical cord, which should be pulsating. Chest to chest time for mum, encouraging breastfeeding. We should already have the mat kit out because it would have come in with us because we were expecting imminent birth, of course. little tactile stimulation, keep baby warm against mum's chest, avoiding that umbilical cord. And then once the umbilical cord stops pulsating 3 to 5 minutes after birth, which we've recorded the time for, of course, 10 centimetres from the baby, we clamp. 15 centimetres from the baby, we put our second clamp. Our third clamp goes the perineum of the mother, and that helps indicate when our third part of the birth is going to occur. I also want to have a quick feel of her tummy and make sure that fundus is hard. I want to have a look at her passage and look for clean up any feces to make her comfortable, and look for any excessive bleeding at that point. I'll be considering using my oxytocin once everything else is stable, and I'm happy with her obs and the baby's APGAR, which my partner should be getting, and checking the pulse rate of the baby to make sure the baby's in a good way and we don't have to start those other procedures of resus for baby. Transport options, closest maternity or her planned maternity would be fabulous. If they're stable, if they're not, the closest ED would be lovely. I think that's about it. I've probably forgotten stuff, but c'est la vie.